I'd like to thank all of you for this extremely rich and informative discussion. But before concluding, I'd like to get some final thoughts from each of you. Maybe we'll just go alphabetically. I'll start with Dr. Brass.
Sure. I think there are only a few healthcare interventions that I would label as public health best buys. And I mentioned generic statins, I mentioned treating hypertension, and I think the recent analysis around icosapent ethyl in high-risk patients puts it in that category as a public health best buy, and that we should be considering how to best implement these data to reduce cardiovascular disease risk to the greatest extent to the largest population.
Yeah, really good thoughts. Let me turn to Dr. Budoff.
Yeah, I think, going from cost effectiveness towards clinical effectiveness or event reduction, I think it also, icosapent ethyl ends up giving us the biggest bang for our buck as far as event reduction. We've seen 25 to 30% plus event reduction by adding icosapent ethyl to statins. And that at least, not head-to-head studies, but significantly larger number than what we've seen from other therapies like ezetimibe or PCSK9s. Even the diabetes agents, SGLT2s or GLP-1s, have not achieved that event reduction. So I think that incremental benefit for our patients in the right patient, the patients with high triglycerides, and will be very beneficial for our individual patients.
Terrific. And Dr. Cannon?
Thank you. I think the conversation has been amazing, and I think it's highlighted many of the advances that we've had in this area. Ultimately, though, we need to find these patients, and I think having appropriate strategies that identify the patients that can benefit from these therapies is really incumbent on all of us. And as we look at our clients and those employer groups that we take care of, how do we, within their population, identify those patients that may not be looking to go to the doctor, but are at high risk and could definitely benefit from these therapies, is one of those things that we're really focused on. And I think it's a huge opportunity for us going forward because we now have a lot of treatments that'll benefit our patients.
Great. And Dr. Navarro?
So I'll just piggyback on the last comment around finding the patients. And if we look at PCSK9 inhibitors, we did a lot of work showing high rates of rejection by payers and high rates of abandonment due to copay. But even if every single patient that had been prescribed a PCSK9 inhibitor was able to get on it, we would have only been treating about 1 to 2% of eligible patients in the United States. So the reality is that a lot of the burden still rests on us as the providers in identifying and prescribing the right treatments for the right patients. We still don't have every eligible patient on a statin or on appropriate antiplatelet medication. And so there's a lot of therapies in secondary prevention that we have yet to reach the full value of because we're not getting them to the patients that need them. So we need to do a better job of shortening the time between when a new therapy is made available to us and when we have the majority of our patients on that treatment. I think given the remarkable cost effectiveness, if not cost savings, of icosapent ethyl, we really have no excuse to not be treating all of our eligible patients with this therapy, or at least giving them the opportunity to make a decision for themselves about whether or not they want the treatment. It shouldn't be because we're not prescribing it or not recommending it for our patients.
Wonderful. Well, thank you again to all the faculty. I found this discussion extremely interesting and educational for me. I learned a lot. Hopefully the viewing audience did as well. Thank you to those of you watching, and hopefully you found this AJMC panel discussion to be educational, to be useful, and to be informative. Thank you so much.